seen that spontaneous depolarization of sites outside the SA node can generate premature ectopic beats. Another phenomenon related to the inherent automaticity of cardiac tissue is the occurrence of escape beats and escape rhythms. In a diseased heart, the SA node may fail to depolarize the ventricles. This may occur either due to failure of the node to discharge or blockage of transmission of the depolarization wave from the node to the ventricles. In these scenarios, the next most rapidly discharging region of the heart, capable of depolarizing the ventricles, will take over as the cardiac pacemaker. In the example shown here, a prolonged period without an SA node discharge, this is termed a sinus pause, has ended with a discharge of depolarizing current from a region of the atrium. This is an atrial escape beat. Following the escape beat, the sinus node has recovered and is again driving the heart rate. The key factor in distinguishing an escape beat from a premature ectopic is its timing. Premature ectopics occur earlier than the next expected sinus beat, while escape beats occur later than the next expected sinus beat. If the SA node does not recover, the ectopic site may take over as cardiac pacemaker, generating an escape rhythm. However, as the automaticity of cardiac tissue declines on moving away from the SA node, the heart rate generated tends to be lower than sinus rhythm. Virtually any part of the heart can generate an escape rhythm. Precisely which site takes over from the SA node depends on the type of problem preventing the node from depolarizing the ventricles. We will go through the nature of these problems in section 5, but for now it is important to appreciate that as we move further distal to the SA node, the heart rate generated by an ectopic site becomes progressively slower. You'll note from the heart rates quoted here that escape rhythms are therefore one potential cause of a bradycardia, that is, a heart rate less than 60 beats per minute. The site of origin of an escape rhythm gives it its name, and the site of origin for both escape beats and escape rhythms can be determined using exactly the same rules we've applied to the analysis of tachyarrhythmias. Escape rhythms arising above the bifurcation of the bundle of His will be narrow complex and may be atrial or junctional. An escape rhythm arising below the bifurcation of the bundle of His is broad complex and is termed a ventricular escape or idioventricular rhythm. We know that this bradycardic rhythm is not sinus bradycardia, as the P-wave axis is directed superiorly. With a PR interval in the normal range, it is likely to represent an atrial escape rhythm, an escape rhythm arising from a focus in the main mass of the atria, outside the SA node. We can identify this example as junctional, as it is narrow complex, completely regular, but with no identifiable P-waves. In this example, the P-waves are likely buried in the QRS complex. With broad QRS complexes and obvious AV dissociation, we can identify this bradycardia as idioventricular. It is important to realize that in the presence of enhanced automaticity of an ectopic site, it is possible for the rate of an escape rhythm to rise above 60 beats per minute. In this situation, when the heart rate generated from an ectopic atrial or junctional site lies between 60 and 99 beats per minute, the rhythm is described as accelerated. Keep in mind that the expected rate for a ventricular escape rhythm is in the region of 30 to 45 beats per minute. So an idioventricular rhythm is described as accelerated when the rate rises above 50 beats per minute. How do we tell such accelerated rhythms are not sinus? By applying exactly the same principles of analysis we used in analysing tachycardias: the duration of the QRS complex and the presence, timing and axis of P waves. If you think about it, you will realise that the presence of an accelerated rhythm on a patient's ECG may or may not represent failure of the SA node to depolarize the ventricles. If, due to some disease process, a region of the heart develops enhanced automaticity and the rate of discharge from the abnormal ectopic site is more rapid than the inherent rate of discharge of the SA node, it is possible for the ectopic focus to override the node and take over pacemaker function. Provided the rate lies below 100 beats per minute, this is categorized as an accelerated rhythm. Of course, once the rate rises to 100 beats per minute or above, the rhythm is designated a tachycardia. Taking all of this information together, when dealing with the arrhythmias discussed in this section, we have a continuum of nomenclature based on the observed heart rate and the anatomical site of origin of the rhythm. This nomenclature is very straightforward.